Hi, my name is Lindsey Roeker, and I'm a hematologist in the CLL disease team at Mayo Clinic. Today we'll be talking about the treatment of relapsed and refractory CLL. So CLL, or chronic lymphocytic leukemia, is a chronic disease, one that we're able to manage incredibly well with the tools that we have, but with the current tools that we have, we're not able to cure. And because of that, we think about treatments over time, so selecting the best treatment at each junction for each patient. The frontline treatment decision-making is really based a lot on disease characteristics and patient preferences. And we have two major classes of drugs that are incredibly effective for the treatment of CLL. We have BTK inhibitors, which are pill-based medicines that go in and tell the cancer cells to stop growing and dividing. Those have typically been used as continuous medicines. We then have venetoclax, which is a medicine that goes in and basically flips a kill switch for the CLL cells and allows them to pop open and die off. That's been used in combination with immunotherapy, IV medicines, as a time-limited combination. We're also getting more and more data available on the combination of BTK inhibitors and BCL2 inhibitors like venetoclax together, and those are some of the treatments that people use in the front line. I bring this up because what you receive in the front line for treatment really impacts our options in the second line or further settings. So when CLL has come back after a first treatment, it really depends on what a patient has received first, why they stopped the treatment that they received first, or whether the disease came back while they were receiving the therapy. Based on those factors, we decide what the best strategy is in the second line. And typically, it's some combination of one of the medicines I was talking about using in the first line setting. So for people who have received BTK inhibitors, they can either be retreated with a BTK inhibitor if they had previously stopped that because of a side effect, or they can switch over to a venetoclax-based treatment if the prior BTK inhibitor had been used while the disease came back. For patients who had received venetoclax-based therapy in the frontline setting, there's often a consideration of how long has the disease been gone since the venetoclax was used. That helps us understand if retreatment with venetoclax is a good idea, or did the disease progress while a patient received venetoclax, in which case we can switch gears to a BTK inhibitor. For people who have received both of these types of treatment and had the disease grow despite use of both of these types of treatment, both covalent BTK inhibitors like ibrutinib, acalabrutinib, or zanubrutinib, or with venetoclax-based therapy, then we have additional options. We have a couple of approved options that work incredibly well for this disease scenario where the disease has come back despite these prior therapies. The first is called Pirtobrutinib. This is a non-covalent BTK inhibitor. So in order to understand why a non-covalent BTK inhibitor is a good idea, let's first talk about what covalent BTK inhibitors do. Covalent BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib work by entering into a CLL cell and attaching to the protein BTK on a specific hook. So the medicine goes in and grabs onto that hook and prevents the cell from doing its normal process where it grows and divides. Non-covalent inhibitors work even if the shape of that hook has changed. So one of the most common ways that CLL cells outsmart some of our covalent BTK inhibitors is by changing the shape of the hook. So the medicine goes in and doesn't have a spot to hook onto the protein. Non-covalent inhibitors work even if the shape of that hook has changed, and it allows the cell to stop growing and dividing by inhibiting BTK, even if that hook is a different shape. So Pirtobrutinib is a medicine that has been studied head-to-head to some other standard of care treatment options and has been shown to help the disease stay under good control for longer than the tools that we had previously. Another approved option that we have for the treatment of CLL that has come back despite use of covalent BTK inhibitors and venetoclax-based therapies is called CAR T cells. And CAR T cells are a normal part of our immune system that we take out and send to a lab, and then we reprogram those T cells so that when they go back into a patient's body, they're able to find the cancer cells and fight them off. This is a therapy that can be incredibly effective for a subset of patients. And if this is a consideration for you, your doctor will talk to you all about the process of undergoing CAR T therapy. In addition to these approved options, including Pirtobrutinib and CAR T cells, we also have other types of medicines that are in development. So these are medicines that are in clinical trials currently and have been shown to be very effective for the treatment of CLL, but we're trying to figure out how to use them optimally, both from a dose, what is the most effective dose for this treatment, as well as how should we use them most optimally. One class of medicines that's shown a lot of promise is called a BTK degrader. So we've talked about covalent BTK inhibitors, the ones that attach to a specific hook within the protein. We've talked about non-covalent inhibitors, ones that work even if that hook is a different shape. And then there are BTK degraders, which go into the cell and they get rid of the protein altogether. So they allow the cell to break down the BTK protein, thus allowing the cell to kind of live out its normal lifespan and die off, rather than continuing to grow and divide. BTK degraders, there are a few in development and are in various stages of clinical development. So there are clinical trials ongoing where patients have access to these medicines, and these can be incredibly effective even for people who have previously been treated with covalent and non-covalent BTK inhibitors. In addition, we're learning more and more about the use of bispecific T-cell engagers. So these are medicines that go in and hook onto the cancer cells and grab part of our normal immune system and bring them together so that the normal immune system is able to fight off the cancer cells. This is another class of drugs that is incredibly effective for CLL, and we're learning more and more about how to use these medicines safely and well for patients who have had their disease come back despite other treatments. So this is a field where we have a lot of great approved options. We also have some really exciting drugs in development. And overall, the treatment of relapsed refractory CLL requires consideration of what you've received in the past, why you stopped the medicines in the past, and what's most in line with how you want to be treated. So with all of that being said, we're here to support anyone who needs to talk about their treatment of CLL, and more than happy to discuss these treatment options with any of our patients.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."